As you can probably imagine, in a model like ours, one of the most important things for us is engagement with our patients. I would strip away a lot and just say, how engaged are our patients with us? It's a great leading indicator for their health outcomes because it shows not only that they're building a relationship with us and they trust us, but also that they are actively engaged in their own healthcare, which takes two to tango in that way. Measuring engagement can be challenging. We need to measure all the things that truly matter and have real accountability and ownership from folks on the team and proper incentives in place to make sure that everyone feels rewarded for their contributions to the outcomes. We went through a lot of work, 3 or 4 months, to get tighter on measuring engagement, aligning incentives around engagement.
Welcome to Healthcare Ops Wave. It's not only an acronym for how, but also healthcare operations and waves are actually very similar. Both are steady, run in cycles, and have the odd storm in between. I'm Frederik Mueller. I'm the co-founder and CEO of Third Way Health, and we'll bring you the stories that shed an inside look on the humans behind healthcare operations.
All right. Well, welcome to another episode of the Healthcare Ops Wave. We are super excited to have Neil Machar with us. Welcome, Neil. Thank you for taking the time.
Yeah, thanks for having me, Frederik.
Are you ready? I hear this might be the first time that we're doing this, so I'm even more excited.
It's my first podcast. I don't do this very often. So yeah, I'm excited to talk.
Well, let's start off really easily. Obviously, we've known each other for a while, but can you introduce yourself to the audience and tell us a little about your background, what you do today, and how did you end up where you are today?
My name is Neil Machar. I'm the co-founder, CEO of a business called Greenbrook Medical. And what we do is provide a really high-touch, personalized primary care experience for seniors. And we do that primarily at brick and mortar clinics. Our mindset on this is whatever we need to take the best care of our patients. So we do telehealth, we've done virtual, we've done in-home, but it's really just whatever we need to take the best care of them. Started the company in 2021, but I've grown up in healthcare. My dad's a PCP who runs a private practice, and my mom's the de facto office manager and CFO and all things administrative for that office. And so I was raised in that clinic, and my parents were Indian immigrants who landed in Tampa, Florida in 1990. And at the time, I think you're just sort of reaching for anybody who looks and feels like you. And so our entire community back home was, Indian American physicians as well. So not just my family, but I was only surrounded by medicine and healthcare. When I went to college, took the MCAT, this story is going to rhyme with a lot of people probably in healthcare at this point. Took the MCAT, I was ready to go to med school. I have an older brother who's now a PCP and my co-founder, which I can explain in a second. It sort of felt like I was getting a hand-me-down career, just like all the clothes that I had always gotten. I needed a sense of adventure, so decided to try something different. It's almost like I moved away from medicine and from healthcare deliberately and have slowly been working my way back closer to my roots and closer to home. So started, in consulting out of college, trying to learn everything that there was. I worked in finance for a couple of years after that. Spent 3 years as an executive of a venture-backed healthcare technology software startup called Patient Ping, which was care coordination software. Was there for 3 years, and then we sold that company in 2021. And that's when I started Greenbrook Medical.
Wow. So what I think is really fascinating about your story is that in many ways, Greenbrook Medical has a very different growth path than from, Patient Ping, for instance, right? Which was obviously going the full-on venture route all the way through the exit. Can you tell the audience a little bit more about sort of what's the business model of Greenbrook Medical? I mean, what led you to start that in 2021, arguably not one of the years that was where brick and mortar care was really hot, right? Given everything else that was going on. But I'm curious to understand that maybe a little bit more.
Yeah, sure. So I'll sort of tell you what we were thinking as we started the company. Our business model has sort of been popularized over the last 10, 15 years. We're value-based primary care, and we have this very high-touch model, a super personalized, heavy-handed model with very small patient panels, and it allows us to provide really, really great service, all of which is powered by risk contracts that we have with the insurance plans. And so we're not rewarded for the volume of activity that we do, but rather the outcomes that we produce for our patients, which, obviously for everybody in healthcare has been a trend that everyone's been following now for 15 years or so. You're right. You launched the business in 2021. Anybody working in value-based primary care of some kind with some sort of credible story was getting funded. And it was like a hot market. It was very easier, at least than it seems to be now, to raise money. But we made the decision to not raise money and to bootstrap the company at that time really deliberately. But, before I touch on that, I'll just share this space that we operate in of value-based primary care for seniors, predominantly with Medicare Advantage plans. There's a lot of companies out there that for the last 10 or 15 years have been sprinting at this and trying to solve this problem for seniors. And for us, the model's been around for 40 years or so. Medicare, what became Medicare Advantage, was first introduced in the late 80s. And it's no surprise that all the institutional interest in the space showed up in the early 2010s with the introduction of Medicare risk adjustment. 15 years later, by 2021, we were sort of starting to engage in this national conversation of like, is Medicare Advantage good? Is it not? Is it costing more than traditional Medicare? Are outcomes actually better? Is this risk adjustment thing really good? Like all of that was starting to happen already. And we had a really interesting perspective on this, we being me and my brother, who is my co-founder, our chief medical officer, and that we grew up in this space. So, I mentioned to you that my dad's a PCP who runs private practice, and he settled in Tampa, Florida in 1990. At the time, Humana was a fledgling startup and looking for PCPs to join the network, and they approached my dad and offered him a practice, and he took it. So from 1991 to today, his practice has been Medicare Advantage focus, total cost of care accountability for his patients, and all the things that come with that. This really high touch service, investing in relationships with them and all that stuff. And so my brother and I have been sort of watching this market evolve over the last 10 or 15 years. So much activity in the space, really validating what we knew from the time we were little kids, which is like, this does really, really great things for patients. But at the same time, hearing this conversation about risk adjustment and all of that, and is it good, is it bad, and do you need it? And we sort of had this insight based on our dad's experience that, hey, it's not totally necessary to have this risk adjustment mechanism, at least not nearly as big as it is. And if you could, because the first 20 years of his career and his practice, there was no risk adjustment. So the only way to be in the business was to change outcomes for patients and to deliver a better experience. So we launched Greenbrook Medical in 2021, really to demonstrate to ourselves and then hopefully to others that we could build something that wasn't so heavily dependent on risk adjustment, really meaningfully change patient outcomes, and leverage our dad's experience to build a system around that, such that if and when risk adjustment sort of changed, we could grow through that. And we made the decision to not raise money at that time and to bootstrap the business, really to prove that experiment to ourselves and really understand the business before we, involved others and set expectations that we may not be able to meet.
Very interesting. And correct me if I'm wrong, just for the audience, risk adjustment in a super simplified way is that you get paid more per patient if they have higher acuity of disease, right? If they're more sick, you get paid more. And as a result, a lot of nationwide insurance companies have really taken to getting very good at documenting patient diseases. There's many articles out about potentially documenting for diseases that aren't actually real, leading to several billion in what might be potential overpayments per several government agencies. And that led to some changes in risk adjustment, right? Where those overpayments are kind of reduced to remove that incentive. If I'm missing anything, correct me.
Yeah, I think that's the gist of it. And it's very much the tenor of the conversation around it right now. I'd say the purpose of risk adjustment really, in my view, came from a really good place, which is, hey, if we're going to place risk at the physician level or for the insurance plans, it makes sense that your benchmark should change based on the conditions that the patient has. Like it fundamentally will cost and take more resources to take care of someone who is much sicker than someone who might not be. So what started and it was solving an adverse selection problem in Medicare Advantage that had existed prior to that, which is the only people who got access to this experience and these things where the people were disproportionately healthier for the most part. It unlocked the opportunity for this program and these benefits to be applied to a much larger group of people. And frankly, a lot of the folks who probably need it more than less. Any incentive system can be gamed in the same way that a fee-for-service can be and everything else. And so I think there's valid criticism of the way that a lot of people have probably approached it. But on our estimation, it's like very valid. There's probably folks who went a little too hot on it, like anything else. But rather than debate the merits of it, let's just try to prove something where we're doing really great things for our patients, taking the best care for them. Even if the risk adjustment benefits for a change and are reduced over time, which they are being now, we can keep growing through that and deliver great care to patients and have it sustainable in that way.
I love that. And I think what we want to do here on the show is talk a little about the operational side of delivering that care, right? And so just for context, can you share when you started, how, in terms of maybe employees or providers, how big was Greenbrook then? How big is it now? And where would you like it to be in 5 years? Like, what's the trajectory that you would like to go on?
So I'll start with where we are today, which is still quite small. So we're 3 locations today. We've got a team of about 25 people. We've built those 3 locations over the last 2.5 years or so. There was a really deliberate choice to go small, steady, one foot in front of the other, really to prove the care model and the patient experience. Like, can we make this work? Can we do it in a way that's sustainable, where we're building a culture and all of those things before we decide what's the right source of capital and growth for the company? It's really been one foot in front of the other. So when we started in 2021, we opened 1 location. And when you're bootstrapped, maybe what that really functionally means is you do everything yourself. We're not raising a seed round and hiring a team and creating roles and responsibilities. It's roll your sleeves up and get the job done, which is a very different motion than the venture-backed software company motion that I had come from before, but I was excited to do it. And so in that first location, my brother, co-founder, is the primary care doc. We started with 1 medical assistant and a couple of back office functions. And then, me and Raj doing everything else, knocking on doors, creating flyers for ourselves. Like, my phone number was on all of the marketing that went out to answer calls and schedule patients. Like, you're just doing it all. And every time we've opened a location, that dial has started to shift more and more towards essentially just firing ourselves from each of the jobs that we're not best positioned to do and hiring somebody else. And so, today we're at 3 locations. We've sort of proven the experiment. We feel really good about where we are. Our patient experience has been really great. We're super proud of it. We've got a Net Promoter Score of a 96, which we're extremely proud of.
Oh my God.
Our clinical outcomes are very strong. Our patients are quite sick, quite old. We're doing a really great job of taking care of their total health outcomes and total cost of care below the Medicare benchmark, despite all of that. And so we're doing really great for our patients, and all of that translates into healthy, sustainable financial model for the company too. So we're profitable 2.5 years in, feeling very proud of what we've done to date. You asked the question of where we go in 5 years. I think one of the things that we've been really interested in exploring is, if you take a look at all the companies in our space, Farzad uses this term of fellow travelers. If you take a look at all these fellow travelers, we've all done really good work and pushed the agenda forward and tried to create this experience for more patients. But if you add up the sum total of all of it, it's still sort of a drop in the bucket for the national healthcare ecosystem. You look at 65 million Medicare eligible patients, 33 million of whom have a Medicare Advantage plan at this point. And if you look at that subset within MA and say how many of those have a physician who's taking total cost of care accountability for them, it's still in the single digit millions. Like, it's still a drop in the bucket. And, healthcare in many ways is still dominated by the large healthcare incumbents, these massive health systems and the large payers that dictate a lot of the way that healthcare is delivered. And so we've been sort of intrigued by this idea of how do you partner with a health system to proliferate this model. And so we launched a joint venture this year with Tampa General Hospital to do that exactly. So, when we think about where we're going to go for the next 5 years, the goal is very much to build out that partnership in this joint venture, to proliferate our model with their resources and support, and use that as our sandbox for what a health system partnership really looks like, and then, figure out where we go from there.
And I think if we're talking about the operating model, for one, a little bit of a deeper dive around your growth from 1 to 3 sites. And I think you mentioned firing yourself from those jobs. I think that's a really interesting approach because that is so essential to scaling successfully and laying a good foundation. And then secondly, I'm curious what lessons you take into your future growth path from the operating model perspective that you have gained during your time working in high growth ventures, for instance. And also, you mentioned this at the very beginning of the conversation, what lessons you want to gain from a lot of organizations that probably did really great work at small scale and tried to run at this very aggressively, right? And have had problems, right? I mean, ANO, CareMax, like all of those organizations are, have had their own struggles in trying to scale something similar. And there's probably many others that are running into the same barrier.
It's a great question. I'll maybe try to tackle the first one, which I think is a little bit more abstractable than just our industry, around the differences between managing a venture scale business versus the bootstrap 0 to 1 foot in front of the other. And I think in both categories, at least from my very limited experience so far with both, do some things really, really well. And there's like a lot of benefit from both. On the venture side, I think what I learned so much from the patient ping experience, and I credit my founder Jay and the rest of our leadership team with showcasing this, is like what works really well there is building high performance teams that know how to work together and driving coordination and this like massive team of people who are all super motivated, and how do we make goals clear and mission clear and drive in that way. And when you have, one of my first projects there was raising our Series C, which was $60 million. When you fill the coffers like that, the first thing you're doing is, we've got a 12-month hiring plan. Let's hire 40 people. It's like you just start hiring people. And so the job very much becomes, how do we get all these people coordinated and working and growing in the same direction? On the flip side, of the other side of it, on the bootstrapped version, where it's 1 foot in front of the other, it's very much like doing the job that's right in front of you and building process and protocols for it. As we grow as a company, it's going to be shifting more and more to that, like organizational building versus doing. And so I think we're going to sort of tilt in that direction. But I think we'll do so, part of the benefit is we'll do so because grounded in a very practical truth of like, what's the job to be done? What's the absolute focus? What's the next best use of the incremental dollar? And being very judicious about that. I think that's been a really good practice that we've sort of forced our way into because we've had to think so critically about it. And I think you probably always should, but it's easier to be a little bit more fast and loose with it when you've got, plenty of resources at your disposal. So, hopefully the idea is we could get to that scale, but do it methodically and prudently along the way.
Have there already been inflection points? I mean, I would imagine even you firing yourself from some of the jobs that you've done could potentially be one. And if so, can you talk a little bit about those? And also, where do you see future inflection points as your role shifts towards more of the organization building and somewhat away from the operations?
I think I might have said this earlier, but it almost feels like every clinic launch has been an inflection point. And I think the biggest jump was from 1 to 2, where in number 1, Raj was the PCP and we were both intimately involved with every single thing that was happening every day in that clinic. Number 2 was our first at bat of like, how do we drive performance and quality when we're not there every day? That starts to get your mind into a whole different operating motion. And sounds very basic, but installing simple things like creating visibility and incentive alignment, performance management, and all of those things, which were really impactful. And I think at number 3 now, we're really benefiting from having laid all that foundation for number 2. We're now stepping into a point where we've sort of set a target for ourselves a couple years out on getting to medium-ish scale. So we've got 3 locations today. We'll want to have 8 to 10 in a couple of years, in about 3 years' time. And what we're doing, we're sort of staring at that hill and going through another inflection point now, which is building our leadership team to really deliver that. So we've recently brought in a chief people officer. We're hiring a head of operations right now. And so it's beginning that tilt towards the organization building in a way where it's going to feel different. I think 6 months from now, we're going to be operating like a very different team. And so I'm excited for that, but it's going to be an inflection point for sure.
I've seen the job posts and, that is very exciting. How do you think about, as you scale this, about this sort of push and pull of centralizing certain things and activities versus keeping them at the clinic level?
Yeah, it's a good question. We're sort of actively thinking about it on a function by function basis. In general, we operate pretty lean teams and we create a lot of ownership and space for those folks on the team. So, for instance, like one of our clinics will have a primary care physician, a center manager, and 2 or 3 medical assistants. And that team of the center manager or the medical assistants has specific roles or responsibilities, but they're all quite cross-trained on each other's responsibilities too. So we'll have someone in the front office, someone in the back office, someone largely handling referrals, but they all understand deeply how to do each other's jobs. And we like that versus hyper-specific swim lanes because in a way, operationally, someone calls out and it's like very easy to fill the gaps. And it means that our team is quite fluid and also it requires a little bit less coordination because once you get to this point where everybody's deep in their swim lanes, now all of a sudden the peer-to-peer coordination, communication, there's opportunities for things to break and all that stuff. So we like having as much as possible actually co-located in the clinic with folks who are cross-trained on multiple things. What that means, though, is that these folks have to be all-stars. They have to be really good at not only their job, but understanding how the rest of the clinic functions and being able to step in and all that. And we fundamentally believe like our job here is to build an A+ team and create an environment where they want to thrive. And so that's been our approach is keep it as much in the clinics as we possibly can, pull as little out as possible, give those folks a lot of freedom and large incentives to do the best work for our patients. That's going to change though. Like it's going to, operating 3 clinics is very different than operating 8. And I think one of the things I'm really excited to partner with our new head of operations on is figuring out what that roadmap is. Like what are the functions that we're going to need to start pulling out? And then just like we've made decisions on every other function to date, it's like, well, as we pull that out, are we hiring someone full-time to do it? Are we outsourcing that function? Are we doing something in the middle with like a fractional person? And so those are going to be sort of function by function debates and discussions and decisions that we make.
That is a beautiful segue to what was going to be my next question, actually. How are you thinking about this, right? You are running a very lean organization. You are also growing at the same time, right? We talked a lot about building A+ teams and the importance. So when it comes to deciding, is this something I want to outsource versus I want to in-house, what are some general approaches that you are taking and how are you thinking about that general concept of in-house versus outsourcing?
It's a great question. And I'd say not one that we have like a really well-defined framework for. I think we handle the decisions incrementally based on the function. But if, one is the most important thing in what we do is the patient experience that we're delivering. And so we've been very reluctant to outsource anything that touches the patient in any way. I think we're fairly committed to that, but who knows what the future holds. But that's been an important first part of the framework, which is this a main driver of patient experience? And if so, we probably want that in-house, building our culture, our performance incentives, all of those things. The areas where we've tended to outsource more are the things that don't touch the patients. And so these are things like billing services. We've outsourced portions of those. Our after hours call, at least the triaging we right now have outsourced, but it's sort of a binary. Do you need the doc right now? If yes, okay, great. We'll write you to the doctor. We've outsourced a lot of marketing activity. And so we've found partners for those. For the things that we've said, okay, this doesn't need to be a full-time person. Let's outsource. Raj and I are car guys. We like cars. And so we reach for, I reach for sports and car analogies probably more than I should. But for our vendor partners, we've often asked ourselves the question once we've decided to outsource, do we need the Camry, the Mercedes, or the Ferrari in this function? And, in the early days, it was Camry over and over again. We need something reliable, it's low cost, gets us from A to B. And yeah, we're going to deal with some issues here or there. It's not going to be the most pleasant experience in the world, but we can't really afford much more. So we lean there. Over time, we've started to make more decisions around, okay, let's get the Mercedes here. Let's get the Ferrari in this function. And a lot of what drives those decisions are a couple things. One is hustle and speed of execution. Despite being sort of a bootstrapped startup, we've set some lofty growth expectations for ourselves and the pace that we move at, and we've got lean teams really bought in. And so it's very hard for us to work with a vendor that's not matching our pace. And as soon as we feel a little bit of that, I've already made my decision that we need somebody else. And the second is the quality of the work and the oversight required. So, if it takes us 5 meetings to get to the place that we could have and should have gotten to in 1 or 2, then it's no longer freeing up our management bandwidth. Like we're having to lean in too much here. So those are the 2 things that, as we look for partners, mean a lot to us and are super important to us just based on where we are.
Wow. I love this car analogy, and thank you for also explaining your rationale behind that. I think it's really interesting. Can you give us maybe a blinded example of when you have a Ferrari outsourced partnership, what in particular made this? Were there moments where you were, if we stick with the car analogy, where you're like, oh yeah, this is nice, right? Were there moments like that? And what particular was that about those moments?
For sure. Yeah. And I mean, I would keep it blinded that they knew who they are. Our video production company that creates all of our video content and marketing materials. This is a partner that we've continued to work with over time. They've been stellar. And it's based on those couple things. You just have extreme confidence in the work product that they're creating with very little guidance from us, and they nail the messaging, ask the right questions. So there's a quality of execution there that requires very little management oversight, and they deliver very quickly and are super professional. And so, in a way, part of the way that I think about outsource versus insource is there's a lot of organizational work that comes with hiring someone and building a function. You need to create performance incentives and alignment, a management infrastructure around it, training and onboarding that person, ongoing cultural development, all of those things. That is a lot of work. And, the best outsourced partners of ours can deliver the same result that you would get from all of that energy without all that energy. And so as soon as you now need to more heavily manage a vendor partner and you're not getting the right result, and so you have to keep following up with multiple meetings and problem solve with them without them problem solving on their own, it starts to tilt towards, well, why am I not just hiring a person ourselves and spending all this energy, on building something in-house? And so that's where some of those vendors that we've used and partners that we've used have really shined, because they lower that burden a lot.
That's so interesting. And I think what is particularly interesting to me is that a lot of what makes a vendor great isn't necessarily that it isn't that easy to measure, right? It's kind of qualitatively like they get it. And I wonder if you have any advice for folks that are evaluating vendors, right? Because what ultimately you're describing, I think, resonates with every single one that has ever hired a vendor. But at the same time, it's also really hard to suss out sometimes early on. So I'm curious if there's specific things that you have found to be particularly indicative or helpful as you are evaluating those partnerships.
Honestly, I hadn't thought about it this way until now that we're talking about it. But one way to think about it is evaluating them the same way that you would someone on the team. For instance, within Greenbrook, we've borrowed a framework that we used at Patient Ping, which is a 2-part sort of system of evaluation for anyone on the team. One is, it's called the what and the how. One part is what you do, and the other part is how you do it, where what you do is a reflection of execution of tasks, delivery of the responsibilities of the role, and that can be, in a perfect world, measured based on the outcomes that we're actually producing from the work. There is a whole nother piece of the story, though, which is how you do it. It is your values orientation. Are you exhibiting the values in the organization, and which for us, one of them is excellence, which is about hustle and bringing your best self to work. And it's not enough to be blinking green light on the dashboard. Hey, I've checked all the boxes for myself. You also need to deliver on the how. Otherwise, you're not a good fit in our culture and our organization. And I think thinking about partners in the same way would be helpful, which is okay, great. You delivered the task, but was it a pain to work with you on that? Were you demonstrating accountability and ownership in this process? all of the same things, the same bars that I would hold any one of our team to might be one way to think about it, because it's not just sufficient to deliver the outcome that you need. It's also about how. Shout out to Tiff Taylor from Patient Thing for that framework. I very much stole it from her, but I love it. So
that is really interesting. And thank you for sharing that. So tell us a little bit about your own successes, right? I think the next 6 questions or so are our lightning round that we ask for every guest. I'm sure you have lots, but what's one of your greatest successes in solving a healthcare operations problem?
Good question. I'd say it's going to be very basic. As you can probably imagine, in a model like ours, one of the most important things for us is engagement with our patients. I think if you were to strip away a lot and just say, how engaged are our patients with us? It's a great leading indicator for their health outcomes, because it shows not only that they're building a relationship with us and they trust us, but also that they are actively engaged in their own healthcare, which takes 2 to tango in that way. And those tend to be the patients who do the best. Measuring engagement can be challenging. And we've got a mindset on everything here, which is that we need to measure all the things that truly matter and then have real accountability and ownership from folks on the team and proper incentives in place to make sure that everyone feels rewarded for their contributions to the outcomes that we have. And so, we went through a lot of work. It's ongoing for the last 3 or 4 months to get tighter on this, on how we're measuring engagement, how we're aligning incentives around engagement, and how we're driving process standardization around the ways that we drive engagement. So these metrics are things like, when a patient first joins our practice, how quickly are we getting them in? Are we making ourselves available to them on an ongoing basis? How often are we seeing them? How many touch points do we have with them in between visits for those who require a little bit more attention from us? Are they completing their annual wellness visits? All of these ways to measure engagement, and then baking those into our performance dashboards for each of the centers. So simple concept, but hard to do in practice, and hard to do and over again. So that's one area that it's ongoing, but I'm super proud of the progress we've made.
Yeah, I mean, it feels like the thing that every provider I speak with wants to wrap their heads around. I'm curious, what are you using some sort of tool for that? Or, I mean, it's very much getting into the CRM realm of things in some ways. So curious what you're actually using to track and report on that.
No, we're not. So our tool is the EMR and Google Sheets around it. And so there's 2 things. It's the EMR, and then it's reports that we get from the payers as well. And we mash those together. And we got a phenomenal business analyst on our team who puts these things together and produces insights from them. So yeah, it's we're almost proudly dialed down on technology at this point, but yeah, no, brute force at this point.
That I love that. And look, I mean, some of the largest businesses in the world run on Google Sheets or Excel, and, rightfully so. So I completely understand why you share that. What are the main things that you pay attention to, right? We talked about metrics. You said you have to be able to measure what is important. What do you look at to understand the health of the business? And then sort of over what time interval do you look at numbers and metrics to understand how the business is doing?
Great question. We do it on a few cadences. One is weekly, another's monthly, and another's quarterly, where we have weekly KPI dashboards that are produced Tuesday morning. They hit the inbox, and that's a reflection of last week's performance in all of the centers and the metrics that matter. And those are really leading indicators. Like, those are in our business, and virtually every business will have the leading and the lagging. Like, we really like to get tight on what are the things that are moving on a daily or weekly basis that give us comfort that things are trending in the right direction, so we're not closing our eyes and waiting for the result to show up. So the leading indicators we all measure on a weekly basis. There's a mix of leading and lagging that we measure on a monthly basis as well. And that's the cadence at which we really test and measure against the plan that we've set forth for the year. Are we on track? Are we behind? And what do we need to do differently?
Can you share what those leading and lagging indicators are?
Yeah. So I'd sort of break it into, there's growth metrics, patient engagement metrics, and patient outcomes metrics. Those are the 3 categories that we measure on a weekly and monthly basis. There's sort of some metrics within every single one of them, but on the growth side, it's new patients being added to the practice, new referrals coming in from different sources. And so all of those sort of pipeline management metrics on the growth side. On the engagement side, it's some of those things that we just measured. So over this period of time, how many visits did we have? How many of our patients who are new to the practice have we seen in the first 30 days of their tenure with us? How many annual wellness visits have we completed? And what does that imply about our cumulative rate over the course of the year? So we measure all of these things, and those numbers move weekly. And then on the outcome side, it's a lot of leading indicators on that front, which transparently, we've done a good job on the hospitalizations front. So we measure things like ED visits per K, admits per K, and how those sort of roll and measure on a monthly basis. And importantly, some other sub-metrics to that. So how many of these patients who arrived at the emergency room called us first? And we try to educate our patients that we're available to them 24/7. So if you need anything, if it's Thursday night and it's 9:30 p.m. and you're coughing and you're a little unsure about where this is headed, pick up the phone, call your clinic, and you'll reach your physician. So we're available 24/7 for our patients. And then there's more on Part B and Part D and management that we've got to do. And so that's one of the things that our head of operations is going to lead for us coming in. So those are the types of things that we measure on a weekly and monthly basis. And then quarterly is more stepping back and thinking about the annual time horizon, or maybe even the 2-year time horizon, and what's going well, what's not, what do we need to build in this next quarter to keep us moving in the right direction.
That's fascinating. And thank you for sharing that detail. I think that always makes it most tangible. Neil, we are up at time, and again, really appreciate it. I think it's so fascinating to hear how you're thinking about this. I love the car analogy, and it really got me thinking about how we evaluate service vendors and what others should be looking out for. So again, thank you for the time and the insight, and I wish you the best of luck for the next part of your growth journey.
Yeah, I appreciate it. Thanks for the time, Frederik. And seriously, congratulations on all the success at Third Way. It's been fun watching you grow this organization and feel your way around. And this whole part of the business has really emerged as something super valuable. So congrats on all that. Excited to keep watching you do your thing too.
Thank you. Appreciate it.